All right, everybody. Thanks so much for joining us today. Delighted to have with us our very special guest, Dr. David Steiger, who is a professor of medicine in the Division of Pulmonary and Critical Care here at the Icahn School of Medicine and at Mount Sinai Beth Israel, and the division chief both here at Beth Israel and over across town at Mount Sinai West. We're thrilled to have you with us, Dr. Steiger.
Thank you, Dr. Weissman. Thanks for inviting me. Such an important occasion. I've been looking forward to this.
Yeah, thanks. Me too. Because, I got to tell you, as a primary care doc, I see tons of COPD and other respiratory illnesses in my practice. And as you know, lots of them I send over to you. So I thought it'd be really good, to start with the basics. Like, what is COPD?
So, Mike, Matt, that's an important question. So let's start off, and I apologize if I'm a little wordy, but I'm going to emphasize certain components of the definition. So COPD is defined as a common, preventable, and treatable disease, and is characterized by specific respiratory symptoms and airflow limitation, in other words, narrowing of the airways. And the pathology is in two main places, both in the airways and the gas exchange areas, the air sacs, called the alveoli.
Mm-hmm.
And usually it's significant to exposure to cigarette smoke, but it's really important to emphasize on a worldwide basis, it's not just cigarette smoke, but it's exposure to noxious particles and gases, with a particular emphasis here in the third world, poorly ventilated areas where people cook. So carbonaceous material, particulate matter. For many people who are non-smokers, they're getting COPD because they live, unfortunately, in poor conditions, socioeconomically deprived, and exposed to a lot of particulate matter.
Which is New York one of those places?
What's that?
Is New York one of those places?
Well, yes, it will be. It will be, unfortunately. There will be many of our patients who live in poorly ventilated apartments, very small kitchens, if that, or studios, and they'll be exposed to a lot of particulate matter. And it's those conditions, just like cigarette smoke, can cause pathology, which we call COPD. And so, as I mentioned, Matt, so the disease is in the airways and it's in the air sacs. In the airways, we call it chronic bronchitis. In the air sacs, we call it emphysema. But what can be confusing is that patients may have airway disease and not just COPD, but they'll have COPD, which essentially affects the small airways. They could have COPD that affects the air sacs, and we call that emphysema. And on a CAT scan, we see evidence of destruction of those air sacs. These patients may have asthma too. So when we talk about testing and seeing evidence of airway obstruction, with all those three common conditions how are we going to differentiate them? And that's what we could talk about, because the treatment options are common and different depending on the so-called phenotype, the specific disease the patient has.
Yeah. So before we get on to that distinction, because I think that's one of the questions I really want to ask. I think you wanted to talk about what a big problem this is, how many people have COPD and how more widespread even than I thought.
Yeah. So I think the first thing I should say, we underestimate its prevalence. And the reason why we underestimate it, because when I refer to that definition of COPD, I talked about airway limitation. To demonstrate airway limitation, the patient is required to have a test called spirometry. A lot of our patients have spirometry performed in their clinic. It can be done in 5 minutes. It's not too difficult, and general physicians can interpret it. Or it may be done in a more scientific environment in a pulmonary function test lab. But basically, spirometry confirms airway narrowing. And the definition of COPD, an important component, is not just symptoms, but airway narrowing, and that's numerically expressed. And because we don't always investigate these patients with spirometry, we are underdiagnosing the condition and therefore missing opportunities to treat this potentially treatable and potentially somewhat reversible condition. So Matt, let me share some numbers with you.
Yeah.
At least 14 million people in the United States have COPD. That represents at least 5% of the population. Mm-hmm. And as I've mentioned, that's probably an underestimate. It's the fourth leading cause of death in the United States. It's thought that maybe there's another 24 million people in America who have COPD and are not being diagnosed because they don't have this test called spirometry. How much does it cost? What's the cost burden? Well, there are approximately 8 million office visits for COPD, 1.5 million visits a year to the emergency room, over 700,000 hospitalizations with COPD, costing a minimum of $50 billion. So I guess in summary, Matt, it's prevalent, it's underdiagnosed, it's costly, and a lot of patients are not being treated. We're missing the diagnosis.
And so who are the people that I, as a primary care doc, that I'm not thinking about, or who that's listening to this or watching this, what symptoms or what exposures or what circumstances should trigger a like, oh yeah, this is somebody I should go send for spirometry?
Yeah, so symptoms are cough and phlegm and sputum production. And the sputum is because the airways are inflamed. And the cough is because the airways are inflamed. And patients will have shortness of breath. They may complain of chest tightness. And the chest tightness is from airway narrowing because the airways are inflamed. The airways are inflamed because the muscles surrounding the airways are contracted in response to the inflammation. And when we talk about treatment, we'll talk about how we have different kinds of inhalers that are able to address that airway narrowing, and hence patients can feel better and their numbers look better. But they have mucus production and they're short of breath.
Right. And that's obviously going on for a long time. This is different than somebody who's got allergies or somebody who, has a viral illness or whatever.
Okay, so Matt, you're setting me up here to talk about asthma COPD overlap.
Please.
Kind of a sexy theme right now because we recognize that patients may have both asthma and COPD. A lot of patients have either asthma or COPD, but many have both. And we like to differentiate the two. Commonly, asthmatics present earlier in life. They're often non-smokers. Often there's a family history and there's a strong allergy history. There's many asthmatics who don't have allergies. And near the other end of the continuum, we have COPDers, usually present in middle age, not young. They cough and have phlegm like asthmatics, but they have a smoking history. Often there's no family history. And when it comes to spirometry, which we talked about before and we'll talk about shortly, whereas the asthmatic, we can define as it's almost a reversible state. The inhalers actually help to reverse the airway narrowing. With COPD, there's significant injury and it's only partially reversible. And that's one way of differentiating the two. Perhaps the age, the absence of allergy history in somebody with COPD or family history, and the fact that when we give them treatment, there's only partial reversibility.
Is there anything on the pulmonary function tests that are suggestive?
Yeah, so both of them will show airway narrowing. Patients are asked to take a deep breath as big as possible and then exhale as forcefully and as rapidly as possible. And we measure how well these patients are able to empty their lungs in the first second and how long it takes in total to empty their lungs. And the more narrow your airways, the longer it will take to empty your lungs in 1 second. And on asthma and COPD, they can both demonstrate airway narrowing. However, the asthmatic, when given a commonly prescribed inhaler, which helps to relax the airways, which some of you may have heard of called albuterol or Ventolin, that reversibly and for a short term inhibits the muscle contraction of the airways, you may get full return of function compared to somebody with COPD. And that helps to differentiate one disease state from another.
Got it. All right. So that's an important fact. All right. So we've found these people because they've had symptoms. We've sent them for spirometry to make sure. Now, how do we treat them?
Okay. So we have a number of medications available. And I should mention, we kind of risk stratify. We help to characterize the patient. So we characterize them, first of all, based on the severity of their numbers, what we call physiology of the spirometry. And then we characterize based on their symptoms, how breathless or not they are. And there's certain scales we can use. And we characterize them based on symptoms, cough and phlegm, and equally importantly, how often they are admitted to hospital. So the management depends on how severe their airway obstruction is, how symptomatic they are, and thirdly, how frequently or not they're admitted to hospital. And there's a so-called Global Initiative for Chronic Obstructive Lung Disease. The acronym is GOLD, and it's made up of multinational group of experts all dedicated to furthering research and education in COPD. They come out with recommendations almost every year. And we, as clinicians, we're expected to follow a kind of an algorithm which describes how we should treat these patients. And we treat depending on the severity of airway obstruction, how symptomatic patients are, and then how many admissions they have. So best case scenario, we have somebody who is mildly symptomatic and their spirometry is not that abnormal. And we'd probably give them a short-acting inhaler. It doesn't reverse the disease. In patients who are both more symptomatic and have more severe exacerbations, and these exacerbations may not warrant hospitalization, but may require antibiotics, may require oral steroids, anti-inflammatory agents, or may require hospitalization. Based on your symptom score and number of exacerbations will determine how many inhalers we give patients. And the reason why we say many inhalers, because what I need to convey, Matt, is that we have the simplest therapies like albuterol and Ventolin, which relax short-term for a finite period of time, the airway narrowing. And then patients with more advanced COPD with more symptoms and more exacerbations, we give them additional drugs that last longer and help to address the inflammation using both inhaled steroids and long-acting so-called bronchodilators that for a longer period of time will help maintain patency of the airways so patients feel better. And the bottom line, why do we do this? Because these drugs decrease risk of exacerbations. And they may change the natural history. And that's the holy grail in COPD, is to find drugs that can, if not reverse the disease, the damage to the airways, is to change the trajectory of the lung disease. You know, after you reach the exalted heights of 35 years of age, your lung function declines. And so just as a rule of thumb, up until age 35, we lose about 35 cc a year of our airway volume. However, if you smoke, you double that rate. So when we talk about treatment, Matt, away from pharmacotherapy and stress smoking cessation, pharmacotherapy is really important, but there are other things that are just as important, if not more important.
Yeah. So I want to stick with the medicines just for a minute so I make sure I have it all straight. So we think about like the albuterols and the Ventolins and these like rescue inhalers. I don't have a great metaphor for that, but I often think about that like wearing a seatbelt or having an airbag when you get in an accident. That, you know, those are the things you want to have around because they keep you safe when things are going badly. Whereas the other stuff you were talking about, like the steroids, the inhaled steroids, might be something that you take to like prevent the inflammation, keep you from getting into an accident to begin with. Is that, have you heard a better metaphor than that?
Exactly. So you mentioned, the cornerstone of the short-acting drugs, then you mentioned the steroids. Now we reserve the steroids for the most advanced COPD. So in between the short-acting drugs and patients with the most advanced COPD, we have longer-acting drugs that help to maintain opening of the airways. They're called long-acting muscarinic antagonists and long-acting beta agonists. And what they basically do is they work on two different receptors, the two different drugs I've mentioned, to help maintain patency of the airways. So essentially we have an incremental scale where we start with the short-acting drugs, where patients feel better quite quickly, improvement in lung function, less symptoms. The more longer-acting drugs, which help maintain the opening of the airways and decrease exacerbations. And then finally, for the most advanced disease, those drugs I've mentioned, plus an inhaled steroid, which, as you mentioned, will decrease inflammation and help to decrease exacerbations.
So people can be on any one of those by themselves,
or
all of them in combination. Is that right?
That's right. So again, getting back to GOLD, the GOLD criteria, the recommendations of the expert panel, for those who have GOLD A or B, they will just have the short-acting drugs and maybe a single long-acting inhaler. For those patients who have GOLD C and the maximum GOLD D, they have more symptoms and more exacerbations. They will require one or two more long-acting inhalers and inhaled steroids as well.
Got it. And so that's a big distinction from asthma, I guess, because asthma, you would have started inhaled corticosteroids early, probably in combination with a long-acting beta agonist, and you would have not done the anti-muscarinic.
Yeah.
agent.
I should mention, getting back to asthma COPD overlap, because it does include a lot of our patients who may have both. The inhaled steroids, we may start earlier because we're addressing the asthma component. And it does
Mhm.
seem our COPD patients who may have an asthma component and the tip off maybe allergy history or family history or minimal smoking history, they will benefit with earlier use of steroids. So that's a caveat, yeah.
All right, so maybe is now a good time to sort of shift gear and talk about non-pharmacologic therapies? And maybe we
Yeah.
should talk about oxygen at some point. I don't know if that counts as a pharmacologic therapy or a.
No, it definitely does. We could start off with oxygen first. So, well, oxygen we use for patients with the most advanced lung disease, unfortunately, and there are strict criteria that we rely on that help us define a patient who would benefit from long-term use of oxygen. And the literature supporting the long-term use of oxygen is decades old now, but in general, long-acting therapy with oxygen for patients whose oxygen saturation, in you and me, it should be over 93, 94% plus. But in patients whose oxygen saturation is 88% or less at rest, they benefit from oxygen therapy. How do they benefit? They live longer. That's been clearly shown in randomized control studies. For patients who have a normal oxygen saturation, but their oxygen falls with exercise, there's controversy whether oxygen actually benefits these patients with respect to longevity or even exacerbations. But certainly, oxygen therapy for patients with our most advanced lung disease is a cornerstone. And as physicians, or even as patients, one should inquire about their oxygen saturation. And indeed, during this period of COVID, many of our patients are now quite familiar with having home oximetry and monitoring their own oxygen level and should be alert when their oxygen level falls, particularly at rest. Oxygen therapy is life enhancing and it is not addictive and it is not harmful when given in judicious amounts. So, yes, we can start off with oxygen therapy, Matt, and then maybe we could talk about vaccinations.
Yeah, I want to hear about all these non-pharmacologic things that.
So we're going to go through a number of things, but just a statement at the beginning. Both vaccinations and smoking cessation are probably the two most important things as practitioners we should discuss with patients. So, firstly, with respect to vaccinations, all of us as practitioners and you patients should be receiving at least annual flu vaccines. And the rationale is because there's a mortality benefit. And it decreases risk of exacerbations of COPD. Now, pneumococcal vaccines, there's different ones. They decrease the risk of pneumonia and sepsis from pneumococcal pneumonia, which is the most common cause of pneumonia in the community, accounting for at least 15% of cause of pneumonia. We have vaccines for it. There's been newer recommendations, and they're given every 5 years to patients over 65 or those who have significant heart or lung disease or immunological problems or immunocompromised. So, in addition to flu vaccines, pneumococcal vaccines should be given as well. Unlike flu vaccines, there's no mortality benefit has been demonstrated. However, when given with flu vaccines, there is a mortality benefit with decreased exacerbations. So vaccinations are cheap in this country and they save lives. So I really want to emphasize that, Matt.
And now they're easier than ever because people can go to their local pharmacy, they can get pneumonia vaccines, they can get flu vaccines.
Yeah.
They don't even have to wait to come and see me.
Yeah. Yeah. And then, so we mentioned smoking. All right. So I said, first of all, it's so important. Smoking is a risk factor for lung cancer. And the more you smoke and the longer you smoke, the greater the risk. Of course, there are 15% of patients with lung cancer are non-smokers, and there are other causes, genetic and environmental and familial, etc. But smoking is the most common cause for lung cancer. It's a terrible disease. A longer lifespan has improved because of newer targeted therapies, so-called, and because of lung cancer screening picking up early lung cancer. However, smoking cessation is the cornerstone of managing patients with COPD who continue to smoke. And in my office, I offer them different treatment options. The simplest is nicotine replacement. And as you know, that nicotine can be provided either as gum, as a patch, as a nasal aerosol. Some patients take more than one of those modalities. And then in terms of hierarchy, the next and more effective method is giving bupropion. Bupropion is an antidepressant. Now, we don't give bupropion because our smokers are depressed, but many patients who stop smoking complain of feelings of depression, feeling low, because nicotine helps to organize our thoughts, help us focus, and patients miss that. So bupropion has been shown to be more effective than nicotine replacement therapy. It has side effects, but it is one of the tools we have in our treatment bag that we can offer. The most effective pharmacotherapeutic intervention is Chantix or varenicline. And I beg your pardon, let's just call it Chantix. Okay. Chantix has been demonstrated to be more effective than nicotine replacement therapy and more successful in facilitating smoking cessation than bupropion, the antidepressant. It is very safe. Initially, there were concerns about both nightmares and increased risk of suicide. Now, that those warnings have been removed, with further analysis, they have not been shown to hold true. For patients of mine who do suffer from nightmares, I ask them to omit the nighttime dose. So instead of taking it twice a day, they omit the nighttime dose. And compared to bupropion, the antidepressant, and compared to nicotine replacement therapy, it is more effective in facilitating smoking cessation. But I have to be honest and transparent here. Our success is still not great. Maybe 22, 23% of patients who use Chantix, our best drug, will eventually stop smoking. But it certainly does decrease the urge to smoke because the brain believes that you are taking in nicotine because Chantix looks to the brain like nicotine. And it excites the nicotine receptors in the brain, and hence that's how it can be used. I should mention e-cigarettes, Matt, because e-cigarettes have been shown to play a role in facilitating smoking cessation. E-cigarettes are not completely safe. We are inhaling vapor from heated liquid, which may be contaminated. It may contain heavy metals. So we really don't know about the long-term effects of e-cigarettes. And particularly those who smoke adulterated e-cigarettes, they're at risk of significant lung injury. But for nicotine-based e-cigarettes, it may help enhance smoking cessation.
Do you think they're safer than cigarettes? I mean, when I think about those cartoons with cigarettes have, 20 to 200 chemicals in them and, including like rat poison and turpentine and jet fuel and all this stuff. I mean, I don't know much about e-cigarettes except that it's hard for me to believe that anything is more dangerous than cigarettes.
Yeah. Well, e-cigarettes do not contain carcinogens, Matt, and I guess that it would be my answer. There's over 200 carcinogens in cigarette smoke. There are none in e-cigarettes. But as you point out, there's a lot of injurious stuff and potentially injurious stuff, including nicotine itself. So I should put in a plug for resources that are available for smokers who want to smoke. So New York State has a smokers quit line, and it's 1-866 New York Quits. The National Cancer Institute has a quit line. The American Lung Association has a quit line. So smokers out there can go to the internet and find a phone number and can receive counseling. Because, as physicians, we're very busy. We need to, provide time for counseling. But nevertheless, there are these services that are available. I can provide that.
Yeah, I think that's a great point. And, there's data, as you said, about the quit rates of, with the medicine is better than without the medicine, but not as good as we want it to be. With behavioral counseling, those quit rates go up. Sometimes it's hard to get behavioral counseling. We don't always have enough time to do it in the office. And, it's hard to find therapists. It's hard to find therapists who are covered by insurance and will pay for this. But certainly the more counseling people get, the more different resources people get, the better. I sometimes give people advice, and I'm sure you do too, about, throwing away their ashtrays and their cigarettes so that they're not tempted by looking at them. to sort of shift up their routine. So if they normally have a cup of coffee and a cigarette, maybe you drink tea for a week so that you kind of break that habit. I mean, you may have other things that you offer people.
No, I agree, all the above. It is extremely difficult for patients to break the habit. There's a behavioral addiction. There's an environmental context. Often smokers, they are attuned to smoking in particular environments. It's a habit, it's a part of their day, and that's equally difficult to break that kind of habit.
And we didn't mention, but Chantix is on back order, has been for at least months now. And so while it's a medicine that we've used very successfully in the past, it's very hard for people to get right at this moment. And I'm hopeful that's going to end soon, because, I mean, as you said, quitting smoking is the best thing people can do for lots of parts of their life, usually.
So the US Public Health Service talks about the 5 A's: asking a patient, advising against smoking, assessing readiness to quit, assisting counseling, as you have described, and arranging follow-up. And it cannot be underestimated, addressing smoking cessation using that kind of template.
Great. Well, we're just about out of time. I mean, I really appreciate your time with us. And that feels like a good place to end, because not only is that a treatment for COPD, but it's also a preventive for people who don't have COPD or don't have COPD yet, that the sooner they stop smoking, the better vaccinated people are against these respiratory illnesses. The more ex-smokers are screened for lung cancer, the more we're preventing or catching early all of these illnesses. So thanks for spending some time with us. Thank you, everybody, for joining us.
Thank you. Thanks. Good day. Bye-bye.